Welcome to the NewlyMeds Podcast. Any views or opinions expressed in this podcast are our own and do not reflect the views of our employers or affiliated organizations. This content is for informational purposes only. Always follow your local policies, protocols, and medical direction.
All right, guys, and welcome back officially now, the long-awaited Season 2 of the NewlyMeds Podcast. We had a little bit of a delay getting things out, but with that comes some amazing new updates. We are now live on YouTube. We have some video on the platform as well. And in Season 2 going forward, you're going to see Dan join me on the podcast as our full-time co-host. We are going to be bringing the similar content that we've been doing, some pre-hospital tips and tricks for the new paramedics, seasoned paramedics, nurses, physicians. Really, anyone in medicine can have something to gain from this podcast. But we are really focused in on paramedics that are coming out of paramedic school, new to the field, and really trying to gain their own feet and get their feet wet in the waters of what EMS has to offer. So before we jump into today's episode, you all know a little bit about me as I hosted the last year, but I recently obtained my bachelor's in nursing and my RN, and I'm working in a critical care unit. Thanks, Dan. I appreciate that. So I'll be working in a critical care unit, and I've been a paramedic for a little bit of time now. Definitely don't know everything, but I love to learn. I love all things medicine and critical care. And I just love sharing some of my experiences with all of you. But as you know, many of you know a lot about me. I'd like to introduce Dan, who's now going to be joining the podcast full time with us. So Dan, why don't you tell us a little bit about you and your background and how you got here?
Yeah, thanks, Will. Again, congrats on graduating. As a huge accomplishment. I'm super proud of you for that. So I was on the podcast about a year or so ago while I was probably about a year and a half ago while I was still in medic school. And since I was last on the podcast, I've graduated medic school and have been on the street for about a year now. And again, same as you, I'm finally starting to have my own set ways and things, have much more comfortable with my routines, but I am nowhere close and never will be close to knowing everything. So I think it's very important that we, continue to have these conversations. And where we came from, I remember we were working nights together in an urban service, and routinely just sitting in our little office there, talking about trying to solve all of the problems in EMS. And while I don't think we're ever going to solve all of the problems, I do believe that the direction that we're going, we can certainly help people with some of the problems that we've encountered along the way. Medic school is grueling. Medic school is accelerated, and there's a lot of information thrown at you that you're expected to know, that frankly you just don't have time to fully process and spend a lot of time with that information. And frankly, and this is no slight to the medic programs out there, but there's just not enough time to cover everything that we realistically should be covering. So we find that there's just this gap in knowledge that should be there, but it's the stereotypical, it'll come with time and it'll come with experience. And while there is truth to that, we want to take part in trying to help instill some of that information, so that way you don't have to find yourself wondering what you're supposed to do next in some of these scenarios that are a little bit more complex that we never really had time to go over. We'll get to that next week, and next week kept getting pushed back.
Yeah, I think you make a great point, Dan. We really, in medicine all around the board, but especially in EMS, we really live in that gray environment. And paramedic school gives you such a good background of information and medical knowledge and skills, and it builds on top of even that EMT education you got. But then you live in that gray area that I've never seen this presentation before, or I've never had experience with this, I've never done this skill. And we didn't really hit on it that hard in paramedic school. And so really the point of the NewlyMeds is to talk about that gray area and look at different problems and patient perspectives and scenarios from a different point of view, maybe one that you didn't cover, and diving into some of the evidence that supports doing these interventions. So with that being said, there's some exciting things coming with our podcast. Dan and I, like I said earlier, have the YouTube channel. We're going to be posting some Instagram Reels. But today we're really going to be focusing on chronic respiratory problems and specifically looking in at our patients that are having acute exacerbations of COPD. And how do we really treat these patients? Because I think in paramedic school, they give you a good background for respiratory patients, but you don't always talk about some of these situational patients and patients with certain disease processes that we see a lot. We see a lot of COPD patients, but we don't really see the type of exacerbation they're in. Are they hypercapnic? Are they just chronically emphysemic? Do they have a lot of airway tightening or air trapping? And the different pathways of treating these patients really vary based on their presentation and even some of the interventions that we do in the field that give us a little bit of a background into it. So without further ado, I want to jump into that topic a little bit with you, Dan. Let's talk about COPD and dive into some of the treatments that we can do in the field. And not only that, let's talk a little bit about what is actually going on in the body when we encounter these patients in the field. So Dan, we get called out all the time to these class 1 breathing problems or class 1 sick person and, short of breath, very limited CAD information. What crosses your mind when you start to think about these acute on chronic issues, especially when you see CAD notes of 70 to 80, maybe even older geriatric population of patient with a respiratory problem?
I am maybe a little bit different in that I just don't really take much into account from the CAD. I expect there to be some type of chronic issue, and I try not to go in with any type of thought process because I feel that kind of leads us down a pathway that may not be there. So if I go in, the dispatcher says, oh, they have COPD, and, they tried their inhaler and it didn't work. And I go in there with kind of that, unconscious bias that I'm going in for a COPD patient. What's the possibility that I miss something that is not COPD? So me personally, yes, I will take all of that information into account, but I try to go in with with a blank slate of let's find out, what they have history-wise and where they are in their current presentation with whatever it is that's going on.
Yeah, I agree. I think looking at the CAD notes can provide a little bit of information on, what you're going to see perhaps when you get there, but definitely don't rely on that information.
Yeah.
And so I think that's a great point and leads me down to my next discussion is when you do get on scene and you encounter these patients, whenever I have a really sick respiratory patient, to me, I always think I'm putting together this puzzle. And oftentimes I try to make things very simple in my mind. I have some degrees and some education that might be a little bit higher level of thinking, but I myself don't really love that type. I like critical care and I love those really thought-provoking things, but I like the simplicity. I like to get things easy for myself. And so when I do that, I see a respiratory patient and I think, what's going on here? Are we having a collapsing airway? Do we have a VQ mismatch in the sense of a lot of air trapping or some sort of perfusion area issue? And with that, I think, how's our gas exchange? And oftentimes we see these patients that are severely hypoxemic and we don't have an untitled, we're obviously not getting labs or ABGs in the field. And so now I'm trying to put together the puzzle piece on why are we here and what is actually going on physiologically. So Dan, I know you have a great background for physiology and coming out of medical school not that long ago, you start to think about some of these things in the field. So talk to me a little bit about what you know about COPD and sort of the things that you think about on a physiologic level when you have a patient that's acute respiratory failure.
Well, firstly, exactly what you said. I'm trying to determine, is this some type of issue that's coming from some type of bronchoconstriction? Is this an issue from alveolar collapse? Is this an issue from some type of fluid in the lungs? I think we often tend to get caught in the trap of it has to be CHF or COPD. Like it has to just be one of those two things, and we don't really dive into, or we don't really think too much into the fact that COPD encompasses more than just one broad definition, right? There could be multiple things within that broad category of COPD that's going on. So I think, it's important to determine whether this is coming from some type of inflammation, some type of bronchospasm, some type of constriction, or if there is some type of fluid issue with that.
Yeah, I think that that's a great point you make. We really need to identify what's going on. And a lot of these patients with COPD, you're going to find the comorbidities. You're going to have a CHF patient with COPD and vice versa, a COPD patient with CHF. And so we're just going to see a lot of these patients that have chronic medical issues tend to have the comorbidities. And so it really makes that puzzle that I try to put together in my mind a lot more difficult, because now I'm investigating, what is actually going on. And I think that Dan and I agree on this topic, but we also have a few different viewpoints that I want to get into. And that's, how do we identify what problem's going on? And I can vividly remember when Dan was in paramedic school and we would talk about these respiratory problems. How do I address it? And so I think getting a cookie cutter way of addressing patients is really dangerous. But I think that having a systematic approach, obviously it's going to change based on each patient presentation, but there are things that I need to look for on every patient. And especially with respiratory patients with chronic respiratory disease process, the one thing that I want to do very close to immediately is, if I'm able, get an end title, because I want to know what their level of carbon dioxide is. And that's not as accurate as an ABG, but it's a place to start. And listening to lung sounds. If
Absolutely.
I'm hearing a lot of liquid, wet lungs and they're hypercapnic, I can have a good idea at, what's going on and going down my treatment pathway. So, that's got to be the place to start with these respiratory patients, is listening and trying to get as many data points, critical data points, as you can. Are they tachypnic? What their end title is, looking at their SpO2, and then letting your mind progress from there. Dan, what do you think about that?
No, and you're absolutely right. I all too often, intercept with BLS crews, and this is not a slight to BLS crews, but on a respiratory problem, and they've been there for enough time to at least do a quick assessment, and that's the first questions I ask. How's their SpO2? What do their lungs sound like? And they know, at least the ones that I routinely intercept with, know at this point that if we're going on a breathing problem, those are going to be the first things that I'm going to ask you, because that is I think that coupled with a good history, taking a good interview, whether that might have to come from family, but regardless of where that's coming from, that coupled with a good history leading up to where we are and why we are where we are, I think gives us profound information within the first 30 seconds.
Yeah, I agree. And bridging into that topic, I don't want to dive super deep into the patho. I know on the NewlyMeds we've talked about pathology a number of times, and I can almost say with certainty that we're going to revisit respiratory pathology down the road. But for today's discussion, just so that we can talk a little bit more about the treatment and some of the clinical keys that you and I think about in the field, so that the newer paramedic and even the experienced ones maybe can have a different perspective on it. When we think about an acute COPD exacerbation, in my mind, there's really only two presentations outside of CHF. Let's set all the comorbidities to the side. There's really only two things that I think about. I think of an emphysema patient and a bronchitis patient. And
Sure.
So eliminating any CHF or diabetes or any of the comorbidities, I need to know if my emphysema patient has this air trapping and the gas is not exchanging. So they have this CO2 buildup chronically. Or do I have a patient who's got COPD bronchitis, and because of the different pathways that can occur with the disease process, they have these really tight airways. And the huge difference for me clinically is that one of these presentations is going to have a much harder time exchanging gas than the other. And so we always talk about this hypoxic drive and hypercapnia and all these buzzwords that we hear about in respiratory processes, but what does that actually mean? And so when I think about it, and I think this is where Dan and I sort of have different perspectives, is I try to, when I assess my patient, diagnostically see where I'm at, because I don't have any x-ray vision or machinery that can tell me what the heck is this disease process. And oftentimes your patient's not going to be, I have COPD emphysema, I have COPD bronchitis, I have COPD. And so now I need to investigate what's actually going on. For me, it's as simple as titrating some oxygen. If I apply passive oxygenation, does their SpO2 improve to the point that I would suspect a COPD patient to have? So I'm looking at SpO2s from 88 to 92%. Because they chronically live with a lot of carbon dioxide in their system, we don't really want a ton of oxygen flush out, because innately that's going to hurt that respiratory drive that they're used to, that they live on. They always have this chronically low SpO2 and a little bit of a higher carbon dioxide level.
Right, and I would just say with that SpO2 level, they're already having some type of respiratory distress.
Mm-hmm.
So, if they're at 90, just because they fall within that 88 to 92, 93, whatever the case may be, just because they're at 90, it's not, oh, well, okay, I mean, they don't actually need oxygen, because, they're within that okay-ish number. Again, basing this off of the patient's presentation. If the patient has the ability to routinely check, or is a patient that keeps up with their health and keeps up with their latest findings at their last doctor's appointment, or whatever the case may be, if we can establish that baseline, then we can use that to go off of. But, at the end of the day, if they're short of breath and their SpO2 is 92 and they're usually 92, that doesn't automatically rule out, the fact that they need oxygen.
Right. I completely agree with you. And I think that we always need to err on the side of, caution, and just being a little bit of that, not that I trust everything that the patient says, but I don't trust everything that the patient says.
Sure.
Yes, their normal might be 92, but let's not take that at face value. Something
Absolutely.
else is going on here. Maybe they're in some sort of respiratory distress. That's obviously why we're calling 911. And so I think that talking about that and talking about a little bit of the pathology leads me down to my next point, and that's, how do we actually treat these patients? And you and I have had extensive discussions about this, and of the really big point I want to make today is, outside of the basic passive treatments, some passive oxygenation, maybe sitting them up. That's a big one that people forget, is we don't want a lot of these patients, especially with the comorbidities, we don't need them supine. If they have the COPD CHF thing, let's sit them up a little bit and see,
Right.
even that might help. But the one thing that I always think about is, at what point do I need to progress through my treatment plan and start thinking about, which is another buzzword, are the non-invasive ventilatory methods. And so whether that be some sort of non-invasive positive pressure, like a CPAP or a BiPAP, or non-invasive in the sense of a high-flow nasal cannula, I'm thinking, in my mind, how can I add PEEP to these patients? Because that's my goal, is I need to have some sort of positive pressure so that I can recruit those alveoli. And so, Dan, when you see these patients, where does your mind go trying to evaluate, does this patient need CPAP? Again, setting the comorbidities of CHF to the side, because your CHF patients oftentimes are going to need a little bit of help pushing that fluid around. So they might need the CPAP no matter what. But your strict acute exacerbation of COPD, how do you evaluate whether they need pharmacological management, CPAP or BiPAP, or both? And then later down the line here in this podcast, you're going to hear a little more discussion about the CPAP and BiPAP.
Yeah, I mean, I think ultimately, fortunately, I've been in EMS for 12 years, so I do have a little bit more of that entrained, the stereotypical sick, not sick of being able to kind of make that quick determination that, maybe coming fresh out of medic school, if you're a 1-year EMT that started paramedic school shortly after, you might not have that yet. And that's not saying that that's not a bad thing. We can certainly work to achieve that and still achieve the same results. But I think, number one, the patient has a presentation that is I don't want to say obvious, but is somewhat obvious that, hey, we are at a point currently in which we have to jump right to CPAP. I'm a big supporter of somebody that needs CPAP, early and aggressive. I think that is something that, for most things when it comes to pre-hospital medicine, early and aggressive. That's not condoning cowboy medicine. That's not condoning, doing things that are egregious or out of your protocols or anything like that. But when I feel like a lot of providers have a hard time kind of pulling that string on going to the next level of escalated treatment. Right. And I think that we have to become more comfortable with escalating that treatment when appropriate.
I think that's such a great point. And to me, I'm going to pose you this question back. When I think about escalating my care, especially for these COPD patients, I start with some passive oxygenation. And if I'm not seeing improvement and they're still tachypnic, I'd rather advance my care to the non-invasive ventilation before they fatigue out, because that may be what they need. And so I'm going to pose you this question is, what are some diagnostics to you to where outside of just experience and seeing these patients, because yes, that does go a long way, but you don't always need the 30 years of experience, the 12 years, 15, 5 years of experience to know when you need to escalate care. Dan, how do you see these patients, and what sort of diagnostic tools and references do you use to say this patient doesn't need CPAP and they need maybe terbutaline or magnesium or these pharmacologic interventions rather than immediately going to a non-invasive ventilatory method?
Well, I think to answer the original question, because I realize I didn't completely answer that, I agree with you. Throw the patient on some oxygen while I'm getting set up for the next escalated step. If I put this patient on, high flow oxygen, and in the time that I can get the CPAP set up, if that is not showing any signs of improvement or showing any signs that there's going to be improvement, then we're pulling the cord and we're going to the next step.
Yeah.
And I think we have, when we're thinking the pharmacological interventions, we kind of go down that same line. We start with some oxygen. Obviously, we're always starting with oxygen. And if it's a patient with some tightness, some bronchoconstriction, and we start with some nebulized bronchodilators, and we start to maybe see some improvement, but minimal improvement, or we might see some physiological signs that they're improving, but the patient is still overall presentation-wise not improving. So maybe we were extremely diminished or absent and or had profound inspiratory and expiratory wheezing. And we start to get some improvement with those physiological findings. However, the patient is still not presenting with a lessened work of breathing. We're going to continue those. We can continue those bronchodilators, and we're going to, by our protocols, obviously, we're going to go down the steroid route. And I think MAG again, in the appropriate scenario, I think MAG is a very underutilized, at least in our area. I can only speak about, the things that I see and the providers that I work with, but I feel like MAG is a very underutilized, pharmacological option for a lot of these patients that it could and or should be used for.
I agree. I think one thing that may come as a little bit of a controversy is something that I'm going to say to you. And I think that we underutilize MAG and we overutilize CPAP. And I see a lot of patients getting CPAP. And I'm not saying that it's a bad idea. I'm not saying it's the worst treatment ever. But perhaps I'm seeing maybe patients that might be better equipped for receiving magnesium rather than the CPAP. And I'm not seeing them used in conjunction with each other really often at all. I have seen a number of charts and heard numbers of stories to where, oh yeah, I was CPAPing my patient, but they never gave Solumedrol or Dex, and they never gave MAG. And maybe the patient didn't need it for sure, but I always come in with that, well, maybe they would have benefited from magnesium rather than the CPAP. It's hard for me. I don't backseat medic. I think that's a really rough practice to be doing. But sometimes I look at the problem as a whole, and I see and hear, especially in this area, we're CPAPing a lot of patients. We're CPAPing a lot of patients. We're CPAPing a lot of patients. But we're not really doing anything pharmacologically for them. And so I think when I think about CPAP, I think, I'm adding PEEP. Yeah, I'm kind of splinting open an airway. But at the end of the day, what am I doing? I'm promoting gas exchange. But if they have a tight airway, I'm not opening any airways. I'm not reducing any inflammation. And so what benefit are you getting? And what do you think, Dan? Do you think we're using too much CPAP? Do you think we're using too little pharm or the perfect balance?
Certainly not the perfect balance.
Right.
I think, again, in the right patient, I think we become very one-track minded, and that we have to go the CPAP route or we have to go the pharmacological route. And like, a lot of people I feel kind of struggle with being able to kind of incorporate multiple options. They think, I have a lot of people that have, or not, I shouldn't say a lot, but I know in talking with people, they've transitioned from a continuous bronchodilator from that to a CPAP, and then didn't continue the bronchodilators. Well, why don't we continue the bronchodilators and still have that effect while achieving at least some type of minimal PEEP to at least have some of that alveolar recruitment there with that. So, I mean, I think to answer your question, I think we do see a lot more, looking back, we see more people using CPAP rather than going down, the MAG route. I believe I shared this story with you. The first time that I took somebody into my local hospital on MAG, the nurse was floored. She literally questioned if I was even allowed to do that. And I'm like, yeah. I mean, number one, I had a medical command order, but number two, like, she had never seen anybody else in the area, and she's routinely there, every night, and has never seen anybody been brought in by EMS on MAG, to the point that she's questioning that that's even a thing. So I think that, again, is very clearly very underutilized, especially in our area. Again, I know a lot of areas are incredibly progressive with how they think down these paths, and I think that's ultimately what we are trying to get to, is that let's expand our horizons of thinking to be able to go down these pathways and not just throw a CPAP on somebody and say, hey, that's good enough.
Yeah, 100%. I hear so many medics, especially medics just coming out of paramedic school, talk to me, and they say they don't even know that magnesium can be used on respiratory patients. And I think maybe it is this area, but I've received texts and emails and DMs from paramedics that just don't even know how beneficial magnesium can be for those really sick respiratory patients. And so it further proves that point that maybe we are just throwing CPAP a little too egregiously, and we need to start addressing the problem at a little deeper level. And so whenever I think about that, you're going to see this theme, and you saw it in season 1 in all of the episodes, is where can I turn to make these concrete decisions? And so Dan and I have looked pretty extensively at some research and some different things. And as always, the literature is going to be linked down into the show notes, as well as in the YouTube description of this video podcast. But a few key studies that I looked at was one by Mosier, and then a second one that was produced in a foreign journal of medicine, a journal of emergency medicine, by Dogan. And I may be butchering the names on both of those people, so I want to apologize if I am. But both of them made some really key points and some recognition. The Dogan study is fairly extensive, but I would look at that because he made some good key PICO questions about looking at treating pre-hospital acute exacerbations of COPD. And the one big key takeaway that I saw from that, and I think that many of you should draw your own conclusions, was something we talked about earlier, and targeting SpO2 levels versus targeting oxygen delivery levels. So specifically was looking at targeting SpO2s from 88 to 92% rather than saying let's do 6 to 8 liters or let's put them on a CPAP at 10 liters. That type of mentality. And then Mosier really looked at 2 non-invasive pathways, NIRS pathways, with a nasal high flow and non-invasive positive pressure ventilation. And so I don't want to dive too deep into the literature because I think we'll have another episode on that. But when you go to take a look at those articles, one thing that really stood out to me was the maybe overutilization of CPAP, but underutilization of BiPAP, because a lot of these evidence-based studies talk about BiPAP. So when we look at the evidence, Dan, I think one thing that really stood out to me was the amount of BiPAP that was used in these evidence-based studies. And in paramedic school, we don't really talk about BiPAP a ton. And again, we could have 9 different episodes diving into these different treatment modalities and the differences between them. But when do you see a benefit that maybe would have more benefit from BiPAP over CPAP and vice versa? And in your mind, why are we underutilizing these treatment plans?
Well, I think if we start by looking at what each of those treatment modalities are, CPAP, continuous positive airway pressure, right? We're achieving a PEEP with that, and that is simply striving to attain that PEEP, right? We're holding the alveoli open, we're holding those lower airways open, and we're allowing for that gas exchange. Whereas when you add in BiPAP, biphasic or bilevel positive airway pressure, right? We are not only keeping that end expiratory pressure, but we're also now adding pressure on inspiration as well. So we're giving that extra pressure during inspiration, and that when we're looking at the difference between the two, that is when we are not as effectively breathing as what we should be at baseline, right? That giving that extra pressure on the inspiratory side allows for a more effective breath, allows for better oxygenation, as well as allowing that PEEP on the back end to keep those airways open and allow for that improved gas exchange.
Yeah, and I think you make a great point with the BiPAP is you get a little bit better gas exchange. And innately, we see this in critical care thought processes between the IPAP and the EPAP, our inspiratory positive airway pressure and our expiratory positive airway pressure. If our IPAP is greater, we're going to have a better job flushing out some of that carbon dioxide. Whereas with this continuous PEEP, yes, we're getting a lot of end expiratory pressure. We're getting our alveoli recruited and open, but we're also then opening up that entire airway. So especially in our COPD patients where they have these areas of dead alveoli that I could give them endless amounts of PEEP, and we have this chronic lung scarring and gas exchange just is not going to occur at that level, we're still going to run into the issue of, is this patient hypercapnic? Right. And I think that really sums up.
Because of all that dead space and trying to ventilate through that dead space.
Yeah, and I think that sums up really what we're trying to hit at hard in this episode. So as I start to wind things down here, if you've ever spoken to me as a paramedic, and Dan and I have talked about this extensively, and I know a lot of providers that have worked with me are probably smiling when I say this because they've all had the famous, or I should say infamous really, CPAP talk, is I think that we use way too much CPAP. And especially when we don't have the control that you might get in critical care or even in the hospital with a ventilator, we use a easier form of CPAP with a device that is very good, don't get me wrong, but I can't manually change the FiO2 and I can't manually change the PEEP. I have really only one factor available to me, and that's my oxygen delivery system that, based off of a calculated formula, gives me this amount of PEEP. And I can add a little more and a little less, but I can't really change my FiO2 delivery. I can't really change my PEEP without changing a fairly sensitive setting. And that setting would be my oxygen delivery. How many liters per minute am I giving this patient? And I just think that overall, when we give the patients this CPAP, it's not always comfortable. And the big thing that I want to pose to a lot of paramedic students and new paramedics and clinicians everywhere are, what is the goal and the achievement that we're trying to do when we're entering these treatment modalities? And for me, if I'm giving CPAP, I'm trying to promote gas exchange and keep the alveoli open. And I really think of that when I have these emphysemic patients who need that help with the gas exchange. They don't really need their airways opened pharmacologically a ton, maybe a little bit, and we can do those short-acting bronchodilators. But my goal is, how can I promote the best gas exchange? And with the tools in our box, CPAP does a very good job at that, because I can push air down into the alveoli and I can promote this gas exchange from occurring. And so I always see this in the field, and I talk to paramedics extensively, that ask me questions about CPAP, and I'm like, what are we trying to achieve? Like, if they were exchanging gas fine earlier, but they were still tachypnic and saying they were short of breath, why are we using CPAP? Maybe we should go toward that MAG or different pharmacologic route, or looking at different non-invasive ventilatory methods, maybe even outside of CPAP. And maybe we get BiPAP or something on board if you have access to that. Right. But Dan, what do you think about when we talk about this?
Well, no, and I do agree. I know you said earlier that there was, maybe a slight disagreement. And I do ultimately agree with that. I think ultimately these decisions need to be made based on exactly what you're saying. What is it that we're trying to achieve? If somebody is having a reactive airway, there's tons of inflammation, and that's what's causing this as an issue. I mean, yeah, sure. Are we going to have some type of better result with a CPAP? Yeah, probably. But that's not the end goal. That's not achieving what it is that we are ultimately needing to do to fix the underlying problem, or at least, have some type of effect on the underlying problem. Whereas, if we have, again, going back to the CHF, or even, even our COPD, or our emphysema patients, if we're needing that gas exchange and we're needing that alveolar recruitment, then that's what we're trying to achieve. So it does ultimately come down to understanding what it is that's causing this presentation, understand what it is that is causing this patient to be in respiratory distress, and understanding the pathophysiology of these different processes allows us to tailor that treatment plan. Not two patients are going to be the same. Correct. Not two presentations are going to be the same. So we need to have a good understanding of what it is that's causing those. And I know you said earlier, and maybe we do another episode, because I know, we don't want to get too long. Maybe we do another episode where we go in depth on these different, on the actual pathophysiology of these disease processes. And so that way that helps, can maybe help somebody understand that better. But if we don't have an understanding of what it is that's causing this issue, then how do we tailor that? And I think that is a large portion of why we see too much CPAP. It's like, well, if 15 liters on a non-rebreather didn't work, if I shove air down their throat, then that'll hopefully help. Right? That's got to be the answer, right? So I think that is. And I don't want to say that the people that make this decision don't know, but I think in that split few moments that we have for decision making, coming up with those differentials and understanding what it is that the patient is telling us, not necessarily with their words, but with their presentation. What is this patient telling us? I think, I think a lot of it comes from a lack of confidence in being able to make those determinations of what it is that's being said.
Yeah, and I want to just circle back to the point that you made earlier. And as we wrap this episode up, you mentioned that no two patients are the same. And in my tenure in medicine, I think it's really important to look into the mirror. And I can recall being a very young paramedic alone, and I had a very sick respiratory patient. And this sort of stemmed my love for respiratory pathology. And you've heard this story, Dan, but I thought the easy fix was CPAP. Right, I was doing the nebulizer. I had already done the Solumedrol. I did not do MAG. I had terbutaline in my bag, and I did not do terbutaline. Not saying that that's the best fix ever, but I sometimes have had more success with terbutaline than epi, and this is down the road. But I was like, I have CPAP. She's not doing great. Maybe I just CPAP. And it didn't not work, but it didn't really work. The patient was uncomfortable. At the end of the day, I had no significant improvement to where it was like, oh my gosh, my patient's really turning the corner here because of my CPAP. And it wasn't until a few months later when I had a similar presentation of the exact same patient that I was able to use magnesium. And I have become very close with this patient over the years. She has COPD. One of those patients that sometimes waits a little too long to call. I know we all know the type, but I was able to re-encounter the exact same patient, and my treatment modality was a lot better for her And that was only because of independent research that I made on my own and in discussion even with you and some of my other paramedic mentors that opened my mind to some new treatment modalities. I would have never corrected my issue. And so I think learning these clinical keys and doing your own independent research is the key. But for me, it was making the mistake and then not having a naive outlook and saying there's got to be better ways to do this, because in all honesty, I felt dirty after that call. I was like, I didn't really fix anything. I feel kind of gross because my patient really didn't get that much better. But in my mind, I was like, I did all the things.
I checked all of the boxes.
I did it. So Dan, what is because for me, to all the paramedics, physicians, nurses, students that are listening, especially, for me, it's, learn from mistakes from people before you and ask the right questions. But how do you go about knowing, these are really complex discussions. And like I said, we can go into great detail on them, but how do you go about making these decisions when it's not talked about in school? Because I never knew until I made mistakes that some of these things were available to me.
Well, and I honestly, I echo exactly what you just said. While I did say that no two patients are the same and no two presentations are the same, and there is truth to that, there are similarities, and you can draw parallels with previous things. So to amend my previous statement some with as far as that goes, but I think it is incredibly important to understand, regardless of if you've been a medic for 5 years, 30 years, 5 months, 5 minutes, you have to keep having these conversations. You have to keep taking these presentations that you personally see, taking the treatment paths that you took with that patient, and then having the conversations, like you said, when you and I and we would talk with other paramedics as well about, hey, I did this did or didn't happen. And, we can have that other perspective of, okay, well, yeah, I had in a similar presentation and I went down that MAG route, or even with yours, with that same patient that you had twice, similar to, almost identical presentation. Obviously the same underlying disease process, right? Mm-hmm. And just the polarizing difference in the outcome, as far as the treatment modality goes, of going the CPAP route versus, going down the entire pharmacological tree that we have available to us with that. And so I think having these conversations, going out, doing independent research, I tell paramedic students and new medics and even, relatively experienced medics, and I would say this to experienced medics as well, we have to continue doing research. We have to continue looking at these articles. And I'm not saying you have to have your nose in an article 24/7, but when you have a more complex patient and they present a certain way, do research on that. Yeah. Take that research and compare what you did to what the research is saying, and then start to implement these findings that the research is coming out with. That research is there to drive our treatment plans.
Yeah, 100%.
Just because we don't have a monthly protocol update or even a yearly protocol update, or just because this isn't being pushed out to us doesn't mean it's not our responsibility to go out and find that and incorporate these within our protocols, incorporate these treatment plans and modalities into action.
And oftentimes that research was based off of mistakes that were made so that we wouldn't make the same mistakes. We've learned so much from making mistakes, and it's bound to happen. This is medicine. Like we're gonna make mistakes, but that's
rule one of scientific. Rule one of scientific research is you're trying to fix a problem. You're not doing scientific research on something that's not a problem.
Yeah, and to close on this episode, because I think that's such a great point. We really hit up a lot of topics for the new providers out there. For me, when you get these respiratory patients, do understand that one treatment modality is not the gold standard and will not always fix the problem. And if I could leave you with one clinical piece of advice from me, it's be the investigator. Listen to the lung sounds, obtain your data points, whether that be digital, waveform, capnography, both vital signs, SpO2 pleths and waveforms, all the things that you can get to make a well-rounded, educated decision and make the best treatment plan that you feel is best for the patient and that you can perform effectively. Do that rather than throwing the cookie cutter, one thing fixes all things. Because in my short time as a paramedic, I know that to not be true. And it just comes with doing the small things right, doing those lung sounds appropriately, accurately, really listening to them to make sure that you get the steps right. Dan, what do you want to leave the new providers with? Because that's who we really talk to with these episodes. We talk to everybody, but this would have changed my perspective on a lot of different things if I had access to this when I was in paramedic school.
Yeah, absolutely. I agree 100% with everything you said. Understand, not only obtain, but understand, I think, I don't want to say a lost art, but I think it is one of those things that also gets lost in the massive information, is understand what those waveforms are telling you. Understand what the end tidal waveform is telling you. Understand what your SpO2 pleth wave is telling you. And I cannot stress enough, one of my biggest pet peeves is seeing somebody listen to half of a breath and move on. I routinely, and yes, I mean, this is time sensitive, but I will listen until you know what it is that you're hearing. It might take that 1 minute. It might take 2 or 3 breaths. Yeah. It might take more than that. Listen and actually get a good understanding of what it is that you're hearing. You don't have to listen to one breath and move on. There's nothing that requires you to, as soon as they breathe in and breathe back out, that you have to move. Listen, 2, 3, 4, 5 breaths. Give yourself time, give your ears time to hear and process what it is that you're hearing. Take that information, and then exactly what you said, we're forming with everything that we take within that picture, but we're forming our treatment plans based on that. And I think that is my big thing that I would say is don't form your plan off of one piece of information. Mm-hmm. That it is a cliche example, but we are building a puzzle.
Yeah.
Take all of those pieces. You're going to miss the big picture if you're not looking at all of the pieces. And I know that that's been said a million times, but we all say that, we all agree with that, and we all hear that, and we're like, okay, yeah, I'm going to do that. And then when somebody is sitting there gasping for air, and we know we need to act immediately, we tend to take 1 or 2 of those puzzle pieces and just run with those rather than taking that extra second to put all of the pieces together to form that plan. And I think, respiratory has been, especially coming out, has been one of my lesser favorite, if you will, call types, because it is, all eyes are on you, and that patient that is gasping, I mean, I know me personally, that's got to be one of the worst feelings in the world, not being able to breathe. And that patient is sitting there in front of you, gasping for air, not able to breathe, and you're the one that has to be able to fix that. So you automatically feel that pressure of, I got to do this and I got to do this now. Using the wrong pieces and not looking at that whole picture, it might make you feel good that you're doing something, but you're not ultimately providing, or if you're missing certain things, you're not ultimately providing the most effective treatments. And kind of like you said, that can leave you feeling kind of dirty after the fact. And it's like, if I would have done this, and I try not to play the what if games in the sense of, from a mental health standpoint, but we do need to play those what if games in the sense of learning from what we did, learning from what it was that we saw, how our treatment plans, interacted with that presentation, and then taking that to build our bank of how we're going to appropriately address that moving forward.
Yeah, I couldn't have said it any better, Dan. I mean, we are in a line of work where some decisions that we make can have such a huge impact. And so taking that extra time to put the puzzle together appropriately is the best thing we can do. I think that you summed it up perfectly. So just taking that extra time to put the full puzzle together is the best thing that we can do. And so today, that's going to wrap up our episode on chronic respiratory pathology and pathways, and really talking more about CPAP and BiPAP and the different treatment modalities that we have available. Looking forward, we're going to be putting out a schedule of episode releases tentatively. We're going to try to be doing an episode a month. That may not always be the case, but I can confidently say that the NewlyMeds Season 2 has a lot of really awesome things to look forward to. We're definitely going to have some more guest speakers. We have our video now as well as our podcast. So you'll be seeing us on all the big platforms. We're still going to have our Apple Podcasts and Spotify. You'll now see some Instagram Reels, and we're on YouTube. So
go check out the YouTube. Will be at the handle the NewlyMeds Pod. And by the time that this is up, you'll be able to start seeing us over there as well. We have some exciting things, even as far as by the next time you see us on video, we'll be looking even better. I mean, nothing's going to change the way we look, but you'll be looking even better as far as our overlay goes for this. And so definitely make sure that you go check us out over there. I know we love to hear from you guys. If you guys have any suggestions on what it is topics-wise that you want to hear, please, by all means, hit us up on the Instagram or on the YouTube, as well as what your guys' thought processes are on some of the things that we talked about today.
Definitely. As always, guys, thanks for listening. Turn all the notifications on. We can't wait to bring you guys some more content. We look forward to hearing from all of you. Thank you.